The title of my presentation is Arrhythmia related pediatric cardiomyopathy. I come from Anzhen Hospital, Department of Pediatric Cardiology. In my presentation, I have three kinds of disease. The first type is ventricular excitation-induced dilated cardiomyopathy. The second one is tachycardia-induced cardiomyopathy. The last one is complete left bundle branch block-related dilated cardiomyopathy. First, let's come to see ventricular pre-excitation-induced dilated cardiomyopathy. In 2013, we reported 4 cases of such kind of disease. All the cases were originally diagnosed with idiopathic dilated cardiomyopathy. All the children didn't get good response to anti-heart failure medication, despite of optimized medical therapies. However, once we realized the causality through successful ablation, all the children get totally recovery of the cardiac function and size. These are the ECGs before ablation, and from M-mode echo, we can see the interventricular septum moved in the same direction with the posterior wall of left ventricle. They are moved toward the same direction. And after ablation, we can see from the M-mode echo, the IVS and the post wall of the left ventricle moved in the different direction. And with they moved synchronously, their heart function increased. The diagnostic criteria, these are we summarized. First, the patients all both meet the diagnostic criteria of dilated cardiomyopathy. That is, LVEF is less than 45%, and LVEDD Z-score more than 2. And the ECG showing type B ventricular pre-excitation. All the patients have right-sided manifest accessory pathways. And we should exclude tachycardia-induced cardiomyopathy and other etiologies, such as cardiomyopathy associated with inborn errors of metabolism. And we can see left systolic dysynchronicity, and most of the cases can see thinning and paradoxical movement of the ventricular septum. And M-mode echo can also show such as these changes. And the tissue Doppler and the speckle tracing can show more details. That is, dysynchronicity in contraction between the basal or middle segments of ventricular septum and other left ventricular segments. Through successful ablation, left systolic synchronicity is restored, and in the meantime, the diameter of left ventricle is reduced. That is, say, cardiac function and size gradually returns to normal. And these are the pictures of my patients. From this one, we can see the left ventricle is very big, and the basal and the middle segments of the IVS moved like an aneurysm towards the right ventricle. After ablation, this phenomenon disappeared. And from M-mode, I show you just now, and after ablation, the left synchronicity is obtained. And this picture shows the results of 2D strain. We can see the yellow one shows the basal segment, and the blue one shows the middle segments of IVS. We can see these two segments moved in the opposite direction with other segments. The dysynchronicity systolic contraction is very obvious. After ablation, we can see all the segments move to the systolic strain at the same time, and they turned to synchronous contraction. This is the pulse eye of left ventricle global longitudinal strain before and after ablation. You can see this is very, the blue one is the obvious synchronary, and after ablation, they return to normal. This is the left ventricle circumferential strain at the basal level. The synchronous contraction is very obvious. And we published this article in 2018. It is a prospective study. The conclusion is that right-sided accessory pathways may impair ventricular wall motion, resulting in decreased LVEF and increased LV diameter. And our article is cited by PACE-HS expert consensus statement in 2060. And nowadays, WPW pattern with ventricular dysfunction presumed due to dysynchronicity in larger patients or young patients has been listed to the ablation. Such kind of patients are suggested to take ablation. And the 2019 ESC guidelines also cite our paper. So I want to tell you that identification of ventricular excitation-induced dilated cardiomyopathy can reverse the patient's prognosis. The prognosis is different with idiopathic cardiomyopathy. It can be cured. They are different. The next disease is tachycardia-induced cardiomyopathy. Such kind of cardiomyopathy is more prevalent in children than adults. Most of TIC result from sustained SVT, AT, and VT. And AT accounts for about 28% TIC in children, just maybe 10% in adults. So this number is very big in children. TIC have an acute or insidious onset. Some cases show incessant tachycardia with relatively moderate heart rates. This case, maybe the heart rate is 220. Just normally, in many cases, they are not very quick. Such kind of tachycardia have a poor response to anti-arrhythmic drugs. The preferred treatment is catheter ablation in children more than 3 years old. And most cases can get totally recovery through ablation. In children less than 3 years old, combined arrhythmia drugs are recommended. And early recognition means early benefit. I have some cases for you. Case 1, this boy is 8 years old, 20 and 8 kilograms. He has a 5-year history of tachycardia. When he was 3 years old, the Holter shows sinus rhythm. Average heart rate is 226 BPM. Normal echo and BNP. He was diagnosed with cardiac cardiomyopathy 9 months ago. Despite guideline-directed medical therapy, his LVEF is not satisfactory. Holter shows the mean heart rate is 212 BPM. Echo at admission shows LVEF is 40% and LVEDD 49 millimeter. This is an episode of the Holter. The P wave, the morphology of P wave, almost except V1 lead. The fifth P wave in V1 lead is negative. However, the former 4 beats P wave is the morphology is different, negative. No, it's not negative, positive and negative. So from this episode, we think maybe the patient has atrial tachycardia, and EPS showed it is really an AT originated from appendage, right atrial appendage, and the boy is very lucky. He got resolved the AT by ablation, and 4 months after ablation, he got a normal echo and ECG. No drugs are needed. Case 2. This is a girl, 8 years old, 20 kilogram. Her chief complaint is intermittent palpitations and dizziness for 4 years. These 2 years, she felt fatigue, worsening, and combined with shortness of breath over the past 2 weeks. Echo shows LVEF is just 20% and LVEDD is 64 millimeter. BNP is highly evaluated. Heart transplantation is advised by local hospitals. When she comes to me, Holter shows average heart rate is 98 BPM. PVC less than 20 sounds to 24 hours. So we can see the Holter, some PVC, and accelerated idioventricular rhythm. And 4 years ago, she suffered from several times of narrow QRS tachycardia. We can see VA dissociation. That means this is a VT, not SVT. 3 years ago, also the echo is normal. And recently, he suffered from some self-limiting dizziness episodes, and it can be terminated automatically. So she didn't go to the hospital. You can see the echo, LVEDD 21%, LVEF 21%, and LVEDD 66%. This is the ECG. And we can see the ECG. The first beat, the third beat, it is a ventricular rhythm. And the fourth beat, it is a sinus rhythm. The difference is very small. It's very small, but they are different. So the patient, when she go to the hospital, I give her some meditations, and the most important is invasive arterial pressure monitoring, and I gave her continuous infusion of amidolone. After the therapy, mental status and appetite improved, dizziness resolved, and blood pressure evaluated, and the ablation, the PVC originated from the left anterior papillary muscle. And after successful ablation, the patient get better and better. This is 4 months after ablation. LEF increased to 50% and LVEDD decreased. And about 6 months after ablation, echo almost is normal. She's very, very good now. So my question is, I have 3 questions. One, is the observed left ventricle dysfunction entirely or particularly or partially attributable to the tachycardia? The first one, does heart failure exacerbate arrhythmias, or is this just a case of TIC? The last question is complete recovery of cardiomyopathy guaranteed after arrhythmia resolution? My answer is, even in patients with established etiology for dilated cardiomyopathy, suspicion for TIC should be maintained, and active management to the arrhythmia should still be pursued to obtain potential clinical benefits. Arrhythmia can either trigger or exacerbate pre-existing heart failure. Another just a case. This patient just 3 years old. He was diagnosed with DCM when he was 3 months old. We can see the LV-EDD when he was 2 months. LV-EDD 42 millimeter, and LVEF is just less than 20%. It's very, very serious, and he didn't get satisfactory effects through meditations. This is his ECG. We can see complete left bundle branch block, and the QRS duration is very high, nearly 200 milliseconds. And this is the echo. We can see a huge left ventricle. Even the apex of the left ventricle is hard to distinguish. It is here. So, very serious. After I perform LBBP for this patient, at that time he is 13 kilogram. After LBBP, QRS is very narrow, and about 3 months after pacing, we can see this is 3 months later after LBBP. The left ventricle decreased, and EF was 55%, and the LVD is 38 millimeter. The synchronally enhanced, and we can see 3 years after LBBP, the synchronous left ventricle contraction is also. And this is 2 years after LBBP. Very good. LEF is normal, and LVDD is 38 millimeter. Now the boy is very good, and narrow QRS and normal echo. Summary. First, pediatric dilated cardiomyopathy has complex etiologies such as genetic, metabolic origin, inflammatory, idiopathic, dilated cardiomyopathy, and endocrine causes. Arrhythmia and dilated, the relationship between them maybe is a causality, maybe it's just a comorbidity. When anti-heart failure therapy cannot produce satisfactory effects, eliminate the arrhythmia and then assess whether the child will benefit from it is my choice. Thank you. Thank you for your